Okay, Dr. Shipp, it's all yours.
Perfect. Okay. Well, good morning. My name is Dr. Andrew Shipp. I am a physical therapist and senior clinic manager. I work over in TP Solutions Physical Therapy. My specific clinic is in Tyson's Corner, basically Vienna, right across the street from the mall. So today we're going to talk about postoperative and preoperative hip and knee surgery, injury, aches, and pains, all of the above. But before we get into that, a little bit about me. Practicing for about 8 years now. I have also completed an orthopedic clinical specialist residency that helps me know and improve my skill set from head to toe, inside and out, all things orthopedics. I'm a sport enthusiast. I just got back from the national track meet this past weekend, coaching kids of middle school and high school ages. And one of my passions is just to help people. All right, so moving forward. Okay, so today our objectives, and again, as we go through this, please either come off mute and ask questions or drop the questions in the chat. I'd be happy to answer them. Now, but today's objectives, as you see here on the screen, understanding hip and knee conditions a little bit, talking more about what happens before surgery, outcomes that we like to look at, if surgery is or is not the answer, things you'll do within recovery, and how to advocate for your health and well-being as you navigate. Okay, so to start out with some data, as an information nerd, I love numbers. Um, just to talk about what it looks like for hip and knee OA is osteoarthritis in our nation, right? So we are 32.5 million people are affected by this condition. The only thing that has a little bit more prevalence is low back pain, which I'm sure everybody's had a little bit of at some point in time. Um, kind of staggering numbers are it's 1 in 4 adults will be symptomatic with this, which is pretty significant. 25% of adults will go through this at some point in time. And when talking specifically about surgeries, about 800,000 happen in the year. Now, those are specifically total hip and knee, not talking about ACLs or meniscus or any of those other ancillary orthopedic surgeries that may occur. Some of the things that bring people into the door, as you see below, and are definitely not limited to joint aches and pains, stiffness, inability to do the things that they really want to do, which detract from their quality of life. So when we're looking at our initial evaluation, some of the things we talk about are what really brings you in and what's bothering you and what can or can you not do. So that's how we kind of start our intake process to get an understanding of what is truly challenging you and how we can frame your plan of care to progress you forward towards those goals that you so desire. Okay, so very briefly, um, is surgery right or appropriate for you? What we like to say is try the conservative means first. So what that looks like are those who are potentially diagnosed with mild to moderate OA, uh, pain with activity, but not specifically at rest. Um, Again, starting to have some of that difficulty with activities around the house, caregiving, appropriate, age appropriate activity, whatever that may be. I know pickleball is a craze amongst the nation, of which I have not played yet. So one of these days I'll get into it as a sport enthusiast. So really looking at what your goals are and what's limiting you, achieving those goals or participating in those things is how we set up our conservative care in the beginning. And if conservative care may not be the thing for you, if you have potentially, again, on the right side of the screen, failed conservative care, we're looking at significant loss of function. That's reliance on assistive devices, whether that's a cane, a walker, even a wheelchair. On the more severe ends, joint deformities, where the joint just is not operating safely. It's really retracting your ability to move about and maintain health and wellness. Um, are some of the, and again, not limited to, reasons and rationales as to why we may say surgery may be. Okay. For more cool numbers about what happens before surgery, as you see here, some pretty good information about why prehab is very indicative for post-op hip and knee. As you can see, 50% improved post-op function after their knee replacement, which is TK, which is a staggering number. And we know from a very, very large dearth of evidence that if you were stronger going into your surgery, your outcomes are that much better coming out. So even if surgery is on the schedule and it's essentially imminent, there's still very, 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 very good evidence that says if you can start some PT, you can start working on your strength and conditioning of not only just the joint, your cardiovascular health, your ability to navigate and use a potential assistive device that you may use after surgery. Um, all of these things on the screen improve, right? If we're talking length of stay, which is LOS in the hospital, we know that can be pretty pricey. So not only are we decreasing your overall disability, but we're also making a dent in healthcare dollar utilization. So we can reduce and improve some of those dollars that are spent by working with these patients and getting you into the clinic before uh, the surgeries. Yeah, who best determines whether surgery is necessary, orthosurgeon or PT? Well, I think it's a little bit of both. I think having a care team, something we'll talk about later, is very, very important. Bringing up your comments, concerns to orthopedic surgeon and your physical therapist, and even your primary health care or your PCP, primary care provider, is very, very important. You are honestly the driver of that bus. You make the decisions if that is something you want to pursue, but having a good team in your pocket to discuss these things is very, very important. I myself love to talk to surgeons, love to talk to doctors about our patients. I have no reserve of hopping on the phone and or shooting a quick email talking about a patient, what's going on and what they may need. So again, make that team, pull those people together, have a good conversation of what is or is not appropriate at that time. Okay. So a little bit more detailed look at what this prehab looks like. Um, in the initial assessment, as I spoke of earlier, we'll ask you 1,000 questions about what's going on, what can't you do, what's difficult. But in that session, we'll also look at your strength and range of motion. We'll look at your functional capacity, sitting, standing, walking, up and down stairs, utilize manual therapy for pain modulation. We'll talk about education of what pain and what it presents like with you. Uh, and just working on general education of what this process may look like, what there is to be expected, and what are the steps moving forward. Kind of those initial weeks of physical therapy when you first get to us. Moving forward, focusing more on strength of honestly from the hip down, right? There's a lot of evidence that talks about low back and keeping the low back strong. That can help hip and knee pain. Increasing balance and proprioception is knowing where your body is in space, because one of the things we do not want to do is fall. I say in my clinic, fall is the biggest F word you could ever say to me, so please do not say it around me. We don't like falls because of all the things that come after falls. You just mentioned length of stay in the hospital. Falls significantly increase kind of a downward trend or an increase of disability after the age of 65. So the importance of balance and anti-fall training is very, very because again, we have a lot of evidence again that says falls equate to not good things. Yeah, quad strengthening and hamstrings. Yes, again, hip down. You want to work on all those things. Quad is the natural knee brace. So the stronger the quads are, um, the better you are to stabilize and stand and even walk. Hamstrings act as a posterior chain stabilizer that helps you bend over, pick up things off the ground, and take that forward step. It controls the limb as you go to put weight on it. So yes, quad strengthening, all that stuff is fantastic. You strengthening until otherwise. You can't go wrong with being strong. is our moniker. Probably should put it on a t-shirt within physical therapy. Low impact aerobic conditioning, such as biking or even aquatic therapy, is very, very good. Uh, Aquatic therapy is not something that we offer specifically in my clinic or my clinics, but a lot of clinics around the area do. Um, Lots of local health clubs have pool yoga and pool aerobics. So getting to those types of things is also very fantastic. Um, in joint mobility work to help the joint mobilize and move as necessary, as needed in order to be functional. Okay. Reading questions. Yes, very good. HEP is tantamount, right? You only get to be around us maybe 2 to 3 hours in the week. So you've got a ton more hours outside of the clinic where you can continue to get better. So understanding that you'll have some additional things to do outside of the clinic that are going to continue to progress you forward and allow you to achieve those goals that we talked about at the beginning uh, safely and appropriately in a right amount of time. Um, those last couple of weeks, we're looking at, well, even early on, functional tasks, sitting, standing, walking, biking, any mode or mean of cardiovascular uh, preference you have, and you will continue to work through that. Advanced conditioning. Um, what's often overlooked in post-op rehab is the implication of cardiovascular health. Um, Blood flow is the healer of all things. So if we have an ability to move blood in and around the body, we have an opportunity to increase healing capacity in and throughout the body. So we'll do some functional testing to determine how far can you walk in 6 minutes. We use that baseline and compare it against your age match normative and say, hey, you're doing fantastic, or we're falling a little short behind where we need to be um, within your age match normative. We'll set some goals. We'll work towards that specifically. Like you said, home exercise program and mental prep for surgery. This is one of the things I love to do is educate as best I can on what can happen um, in, during, and around your surgery. A lot of orthopedic groups do a very, very good job of having a joint replacement class before these surgeries, but sometimes they don't. So I think it's one of our roles in physical therapy to help educate the community on what's really going to look like and what are some things to prepare for, both mentally, physically, environmentally, as you head into these surgeries. And what does sitting do to our quads and hamstrings? So I will always say that sitting too much is probably not the greatest, right? The body likes to be in motion. Body in motion stays in motion. So sitting for too long can cause a kind of a snowball of issues, not only within the hamstrings and quads, but elsewhere within your body. So if anybody wears an Apple Watch or a smart device that tells you to get up every hour, listen to it because it's important. The more we're able to move, the more we're able to, as muscles contract and relax, it helps move blood flow up and down and around the body. So yes, sitting can be a little bit precarious. So as best you can, I would avoid doing it for a very long time. Not only for our quads, not only for our hamstrings, but for general well-being. A good question. Okay. So moving forward a little bit, what does recovery really look like? So in those initial stages, um, one of the most important things we want to do is make sure you're safe. So making sure that walking, sitting, standing from various chairs, stairs, uh, are safe and appropriate for you before we send you home. One of my first jobs, I actually worked in the hospital on a joint replacement floor, and we had a set of stairs, we had a car, we had uh, different heights of chairs that we took our patients into a room and practiced these things to make sure that they were safe to do so. Uh, so safety is the number one thing that guides a lot of our decisions in order to say, hey, we're appropriate for the next step, and or we need to keep in the hospital longer, or even start with some home health physical therapy first before we bring it out into the clinic. Uh, Again, pain management, making sure pain is under control, and range of motion as required for the stage that you're in after the operation. Again, as I mentioned earlier, home health PT is an option. So there's physical therapists that can come into your home and help you in those first initial weeks. Say because you don't have transportation to outpatient physical therapy, or just your general ability isn't where it needs to be, get you out to outpatient physical therapy. Home health physical therapy is a great option to start with to get you started and get you moving. It is very, very important to not wait. Um, Earlier mobilization and earlier care has greater outcomes than delayed care. So do not wait. I would honestly say, if you could, set up these things before surgery. So have your outpatient physical therapy set up and or have your home health physical therapy set up. So as soon as you get out of surgery, you can get right to it. As time goes on and as you progress, we again, as I mentioned earlier, look at more strengthening, uh, balance training, again, falls or no, and functional activities, making sure that caregiving is a role for you, making sure you can do those things. If um, walking is one of your favorite hobbies to do, making sure you can do those things. So looking at more active modalities versus the passive modalities like massage and or joint mobilization, uh, things like heat and ice, which is its own bucket of conversation, whether to heat or to ice as you navigate. That's a question I can answer, if you will. So I can answer this question. Will doing quad, hip, leg exercises help, or do I need PT? Ms. Carolyn, I think a little bit of both is definitely appropriate. Um, just because the surgery was about 5 years ago doesn't mean it's too late to get you back. I think getting a good assessment to determine what is really going on, determine where you need to focus on strength-wise, can be advantageous, and then you can maybe take the program from there. But I would say consider getting assessment just because you've had a surgery some time ago, just to kind of get a good idea of where you stand, uh, and you can get some good assessment to determine whether it's more a quad thing or more a hip thing, um, in order to increase and decrease your symptoms. Okay, return to life. That's when we start to look at some more focal strength conditioning. Um, I like to say you're never too old to lift weights. So we do squats, we do lunges, we do deadlifts, all those things that you see in the gym. We're going to try to do it because those are all functional movements that you'll encounter in life, whether it's sitting and standing from a chair, bending over to pick up groceries off the ground or a little one from the floor. All those movement patterns are necessary. So we want to strengthen as best we can in a way that best resembles what you'll encounter outside of the clinic. And again, looking at some of the hobbies that you want to get back into, whether it's pickleball, bowling, or whatever it may be, making sure that those things are kind of the guiding light as we enter these last weeks of care. Um, and then finally, looking at full return to participation in activity. So looking back into our first couple of weeks, we'll reassess all of our walking paces and capacities. We'll get strength look at range of motion and have a better idea of where you stand to say, hey, you're appropriate for all the things you want to do, safely return to XYZ based on these objective numbers, you are safe to do these. And objectivity versus subjectivity is often very important because fear is a thing, right? You have had this surgery, your hip and or knee is a new environment, uh, and it can be concerning. So what I like to do, again, is educate on what's happening, what's going on, but then show patients the progress that they've made as to where they stood on week 1, week 2, down into month 3, month 4, right? So you can see where you were, how far you've come, to help maybe reduce some of that anxiety or worry about what's safe or what can and you cannot do uh, as you navigate forward with this joint replacement. Okay. So again, evidence and objectivity. Um, Rehab improves so many different things, as we've noted in the evidence, and it's very important if you have the opportunity to do so, to do it. Um, Ask. Some surgeons have certain protocols they like to go through, but oftentimes the surgeons will refer to the physical therapist. But I always say ask if you can. Um, it's better to receive stop people.
Dr. Shipp, can you tell us what the acronym SMD stands for?
Yes, that's a standard measured difference. That's just to say that there's a significant improvement for those who have prehabilitation before TKA as to those who do not. Um, and quad strength is arguably one of the best predictors we can have for a surgical outcome for not only the knee, but also for the hip. So it's very, very important that we keep those lower leg muscles pretty strong. Again, post-op TT is very, very important. It should be considered the gold standard of care. I think oftentimes we have patients who go home for a while and they try to do it on their own. Um, and longitudinally, so like a year later, uh, the outcomes kind of match. But when going through post-op PT, you get to where you want to be faster. Excuse me. So you're able to move safely, you're able to do more sooner if you get into post-op PT versus those who delay their care. Uh, Again, shorter hospital stays, which is also very important as we talk about healthcare dollars and overall mobility. There's been some studies that talk about how deconditioning occurs after 3 days in the hospital. Um, and deconditioning is where you have the inability to uh, navigate to the appropriate speed, tempo, duration, whether it's walking or biking. That deconditioning is clear after 3 days in the hospital. But again, for the group of people who are not surgically a candidate, there's still some good evidence that says that utilizing PT as a first line of treatment can be successful, right, for those to moderate groups. Okay, let me read this question really quickly and I'll get to answering it as well.
If you could summarize the question before you start answering it, we'll all be on the same page.
Sure. So Eleanor was talking about how she did her home exercises after surgery, but she was still having some stiffness. She then got recommended a steroid pack that immediately made a difference and has helped her uh, get to do the things that she wants to do. So, is having the steroid pack a typical or traditional means of care? Not really, but it is effective because what steroids do is they help reduce an inflammatory response. after surgery or after any trauma, your body's going to go through that inflammatory response acutely, which is okay. We need that inflammatory response to help bring in all the good things and break down all the bad things so that the healing process can start. But as she mentioned, this was going on for about 8 weeks, which is beyond the acute timeline. So utilizing that steroid helped her get to a point where the inflammation went down, her range of motion increased, which then allowed her to do the things that she wanted to do. And then our second question from Mr. Paul, how to recovery from a hip replacement compared to recovery from a knee replacement? That is a very, very good question. Medical science has improved quicker in hip replacements than they have in knee replacements. So the hip replacement recovery is a little bit better, but not by a big margin anymore. 10 to 15 years ago, there was a pretty big difference between a knee replacement being the tougher recovery and a hip replacement being the easier recovery. But surgeons and surgical medicine has closed the gap between the two, where knee replacements have now become same-day surgeries. They figured out how to spare some of the trauma that happens with knee replacements, so that's allowing patients to get better faster, and the recovery is a little bit easier, but still not as easy as a hip replacement. But they're definitely closing the margin between the two. Good questions. Okay. So PT without surgery, as I was mentioning earlier, it's a thing. I would always say refer back to your why and understanding, is this surgery necessary? And have you tried the conservative route first? So what some of these things are: therapeutic exercise, strength, flexibility, range of motion, those interventions being tantamount in your program, manual therapy to help with pain modulation, and that big fancy word, neuromuscular reeducation, kind of leads into the proprioception, um, helps the muscles, help the body know and function at a better and more efficient capacity. So you have trouble with activating your quad, neuromuscular reeducation can improve that. If you have difficulty using your hip muscles, neuromuscular reeducation can help that. Again, aquatic therapy, very, very good. There's a lot of biochemistry that happens in aquatic therapy. When you're submerged into water, it can help with reduction of swelling in the lower limb because of the compression effect that happens when limbs are submerged. The offloading effect that happens when you're in the water. There's schematics online that talk about if the water's up to your chest, that's about 95% of your body weight offloaded from your feet. So that will allow you to do more things, maybe move longer to accrue greater minutes of exercise. And the gold standard for exercise is about 150 minutes in a week. So aquatic therapy can be a very, very good means of rehab slash prehab for individuals. And then different modalities, ultrasound, not as much anymore, with TINS and something called dry needling. Dry needling is very similar to acupuncture, but our means of applying is a little bit different. But dry needling can help with activating and getting muscles to function a little bit better. It can help with reduction of pain. So dry needling can be a means for a lot of different things, depending on what you may be having difficulty with. Then again, patient education, knowing what needs to be done and knowing how to do these things or what is to come is very powerful. Also knowing what is appropriate and what is not appropriate activity-wise can also be significantly important, because if you are repetitively doing something that may be causing harm, we need to talk about those things and see if we can modify that activity to still get you to do what you want, but to make sure that you're safe. let's see. Our next question again, Miss Eleanor. Read it for a second. Yeah, very good statement. Um, the hip and the knee work in kind of a symbiotic chain. So sometimes hip things can cause knee pain, and knee pain can cause hip pain or hip dysfunction. Um, so you're right. I think having a clear conversation first about where the root cause is, like what is really causing the symptoms first, to make the determination if the hip needs to be priority or the knee needs to be priority is very important. So I think you're right, Ms. Eleanor. It's all about the conversation you have to determine what issues are causing your pain and dysfunction. Right? We say, what is the victim and what is the culprit? Delineating between the two. And yes, I am by no means a dietitian or a registered dietitian, but there are certain things within your diet um, that can improve your inflammatory response. Um, Processed things such as like chips and crackers, things that come in a box that have a shelf life of 20 years, um, those are not the best for you. So those are inflammatory. Your like raw fruits and vegetables, specifically like blueberries, which have been a hot topic for ever. Tart cherry, uh, beets, those types of things are anti-inflammatory. Uh, so adding that into your diet and removing some of those things that aren't such as or that aren't so good can improve. As it compares to a low calorie diet alone, what can happen sometimes with a low calorie diet is that calories are counted, but they're not accounted for in the appropriate macros and micros. Your macros are your proteins, your carbs, and your fats. All three of those things are very important for healing and physical function. So if you're reducing calories and you're pulling from those three categories, you're not fueling yourself enough in order to put your body in a healing environment, but also not fuel yourself to have enough energy to do the exercises to go about your day. Um, so with warning of a low calorie diet alone versus anti-inflammatory PT is what that's talking about. Awesome question. So again, kind of going through that right side of the screen, exercise is again probably the number one thing that we focus on in the beginning. They are very effective and have some of the most backing throughout evidence for decades at this point. Uh, and then utilizing PT as a way to delay or even eliminate potential surgery if it's possible. And back to a couple questions. Can more flexibility in the knee be accomplished years after firing and knee? Yeah, possible scar tissue as well. So the answer is it depends. Unfortunately, it can also depend on the joint health itself. Something that's often not talked about is the joint being a chemical environment. Um, so again, kind of circling back to the anti-inflammatory talk, you can improve inflammation around the joint just by what you're consuming. So that's a means of potentially improving your range of motion. Uh, but it's not impossible, right? If the joint has scar tissue, then yes, that's going to be a detractor from your ability to potentially achieve more range of motion. Um, but it's not impossible. It may take more time. It may take a little bit more focal uh, range of motion exercises, but I'm not going to say it's impossible by any means. It just has to be very, very specific. You're going to have to work at it very, very often. Okay. The first few steps are the most difficult for me after sitting or laying down. Is there anything I can do? before I stand up to lessen the pain in these transitions? Yes. Uh, Simply doing a couple of exercises while sitting or while laying down can improve your comfort or ability to stand and walk after you've been sitting or laying down. Something as easy as a heel slide, so sliding your knee back and forth in the bed or in the chair. Uh, Glute squeezes, where you're just going to tense those muscles and relax them, tense the muscles and relax them over and over again is also very, very effective. Even seated calf raises, right? The calf actually passes the backside of the knee. So if you can use your calf muscle, backside of the shin, um, that can improve and kind of warm up the knee a little bit. So you have a ton of different options that you can do while seated or while laying down that may improve your transitions. Doesn't have to be anything intense, just enough to get blood flow going. When the joints move back and forth, they kind of lubricate themselves with their natural WD-40. So that will inherently improve your ability to move after being still for a while. As mentioned earlier, uh, make sure you're setting yourself up before surgery. Ask for a PT referral if you can. Um, Making sure that you ask as many questions as you need in those uh, pre-surgical meetings, post-surgical meetings. Ask as best you can. I say physical therapists are some of the best people to ask because you get to see us a lot. So you have multiple opportunities to talk about certain things, questions, comments, concerns, but you got to ask the questions if you have. Making sure you are documenting your symptoms, that's going to better help us know what can uh, what we can put in our program to help improve and move you along your plan of care, which is POC, to get you to where you want. Uh, Again, ask the right questions. What does PT look like? How long will I be in PT? What can I do before PT? All those things are important. Uh, do your homework. Home exercise program is very, very important, as I mentioned earlier. You've got a lot of hours outside of the clinic that are going to be important for your rehab. So making sure you're making use of those minutes and moments to continue to move forward. Then lastly, create that care team, as I mentioned earlier. Make sure those individuals uh, are all looped in. And if you have questions for one and you need answers from another, make that connection if you can to make sure everybody is working towards you um, and making sure that you're progressing appropriately and getting you to where you would like to be. Okay. So let's talk shoes. Yeah, this is one of my favorite conversations. As a runner and a shoe enthusiast, got some pretty good knowledge about shoes. Um, so recently, Miss Wendy heard about Hoka shoes, and now everyone is wearing them. Yes, Hoka shoes are very, very popular. They're pretty good. And there's 1,000 different models and modes for these Hoka shoes. So my first piece of advice is if you can get into a place or facility that can let you try on a couple, do that because there's a lot and it can be very overwhelming. So knowing exactly what may feel best for you, what's safest for you, is going to be important. Versus just the aesthetics, right? The shoe may look good, but it may not be good for you. Um, Comfort is the number one piece of information you should go with. If it doesn't feel good, then it's probably not good for you. They did a research study with the US Air Force where they gave the cadets shoes based on their foot type. They gave shoes cadets based on comfort. The cadets that got shoes based on comfort had significantly less running related injuries than those who were given shoes based on a foot type. Um, so again, comfort is the number one thing you should go with, um, and safety as well. Again, lots of information out there, uh, and honestly spend hours looking on the internet about what shoe is going to be the best or not the best. But if you can get into a facility where you can walk around and try some out, is what I would recommend. Yes. So, do you typically need a referral for PT? Not typically, but it depends on your insurance. So, your federal payers, that's Medicare, Medicaid, TRICARE, and all those small branches outside of that do require a referral. But your commercial insurances, such as Cigna or Blue Cross Blue Shield or Aetna, those insurances do not always need a referral. In the state of Virginia, I'm assuming everybody is within Virginia, uh, physical therapists have what's called direct access. What direct access is that you can honestly call our clinics if you have a commercial insurance, and we can set up your appointment without the need of a medical referral to a doctor or a PCP or a surgeon. But if you have one of those federal payers, Medicare, Medicaid, TRICARE, um, you do also need a referral before coming to PT. A very, very good question. All right, talking a little bit of medication here. So we're talking about Tylenol, surgery. Yeah, so that's a tough question that I don't have a very specific answer for you as it pertains to pain medication. Um, but I think what's going to be important is you make sure you talk to your pharmacist, make sure you talk to your surgeon about different options. Um, and if Tylenol, if you're allergic to Tylenol, then get another analgesic uh, is going to be important as well. Because again, we don't want to chase pain. Getting behind pain is very, very difficult, and especially post-operatively, you want to be able to navigate your pain well so you can be functional and do all the things that you need to do. All right, barefoot running. Yeah, that was a very, very popular trend maybe about 10 years ago. Um, Barefoot shoes are not bad, but I do think not everybody is appropriate for barefoot shoes. We spend a lot of our lives in normal shoes, and to go from a normal shoe to a barefoot shoe can sometimes cause a little discomfort. So what I say is if you want to make that transition into a barefoot shoe, take your time. Wear the normal running shoe for 4 days of the week and use one day of the week to use the barefoot shoe. Do that for a little while, then maybe go down to 3 and 2. So just make sure you're not going cold turkey from a standard running shoe to a barefoot shoe. That's how I would approach that. But again, it's about comfort. Right? Barefoot shoes aren't necessarily the best for you. These Hoka shoes or any of the other brands aren't necessarily the best for you. The shoe that feels the most comfortable allows you to move. The safest is going to be the shoe for you. But excellent question. Yeah, sandals. Sandals have gotten pretty high tech recently. Hoka makes the sandal, um, and they've got some good support and some good cushioning. So there's a lot of alternative footwear out there that exists that aren't running shoes that can be safe and appropriate for joint health from foot and ankle all the way up to low back. Um, Again, explore. Uh, Most shoe companies have a pretty good return policy. So if you buy them and you hate them, send them on back. But again, try out a couple and see what works best for you. Awesome questions. All right, so I left a little bit of time at the end of this presentation to fill as many questions as I can, as appropriately as I can. Um, so I'll stop
Good.
sharing really quickly and we can talk.
Okay, there's one comment here about lidocaine patches.
Yes,
Talk
lidocaine,
about that.
yeah, those are, they're good. As long as they are safe and appropriate for you, then I think that they can be fine. Lidocaine patches, if anybody is unaware, are uh, small patches that either have 4 to 5% lidocaine in them. They can act as a pain reliever in the local areas. You put the patch either on the hip, on the knee, or on the low back. Um, those are appropriate as long as you aren't allergic and you've been cleared by your medical provider. You can go to the store, CVS, Walgreens, and buy them over the counter. They do exist. You can also get prescribed them as well. That would be a conversation you would have to have with your PCP and your pharmacist.
I'm going to head back to shoes again for a second. This is
Yeah.
you can tell I was looking forward to this talk for a week. So, um, right now, my knees and my Achilles tendon is acting up. I've tended to, when I'm looking at shoes, avoided shoes that I've looked more at slides versus shoes that have either a strap in the back or, a 1 inch, you know, your ankle, fits into it. Because I'm assuming that that's going to push against the Achilles tendon. Is that generally, is my thinking on target or off target? Do I want the support back there versus fear of pain?
That's a good question. And I think that it's twofold. Uh, One being that comfort is always tantamount, right? If it's uncomfortable for you, then it's definitely not the right thing. Um, Sometimes the abrasion over the back of the heel can cause Achilles discomfort. But what I would also look at is the slope of the shoe, right? So a flatter shoe is going to put a little bit more tension on the Achilles and heel, like a barefoot shoe, for example. A barefoot shoe is going to be a little stressful on the Achilles versus like the Hokas that we were talking about earlier. They have a more, it's called drop. Most shoes have about a 10% um, or 10-degree drop in the shoe, just kind of naturally built in. So a zero drop is flat, 10% increases, so on and so forth. So what I would also encourage you is to look at a shoe with a little bit more of a drop to see if that can offload the Achilles a little bit and give you some more discomfort.
Mhm.
Or more comfort, less discomfort, more comfort,
Right.
and see if that helps you.
So I know that there's a running shoe store in Falls Church on Broad Street that
Yeah,
has the whole range, and they have as many machines to test your foot as they have shoes.
they
Um,
sure.
they appear to be more serious than I'm able to accommodate. Is something like Comfort One, and I know this is all just opinion. Um,
Mhm.
do you, do you think that, I guess just without going so sophisticated,
Mhm.
as a running store, can you still find enough variety to sort of do something better? I'm getting your point now about the elevation, because I'm just sitting here and I'm feeling if I go up on my toes, there's less stress on the Achilles than when I'm sitting with my foot flat.
Yeah, I think finding a facility or finding a place that can meet you where you are is also important. Uh, you don't necessarily have to go to a road runner, Potomac River running, big,
Mm.
big ones in this area. Um, but any boutique shoe store that can kind of sit down and talk to you about the shoes that they have to provide is also satisfactory, right? And I think making sure that you're getting educated and you're giving options is probably the most important thing that you can look for in a shoe store.
Great, thank you.
I had a question. It seems like every couple of years, there's a news story out about some new attempt to regrow cartilage inside a knee joint. And it's all, just around the corner, and it never seems to actually happen. What's the current state of that kind of research?
Yeah, I think medicine is still pretty far away from being able to do that successfully and safely. Um, there's some studies being done overseas in uh, injection that can help with that increase in the growth of. So cartilage is made up of like small little itty bitty fibers, and what this injection does is it helps stimulate the growth of those fibers uh, to then create collagen to then create cartilage. Um, they haven't been able to do safe, successful in humans just yet. And I think that's where the ceiling is right now, is to get them into true clinical trials with enough people to say that, hey, this evidence is supported by this intervention. And we're just not there yet.
I know, I know I said my shoe question was my last question, but it really wasn't. Um, so the other thing I did post to avoid surgery was low dose radiation.
Mm,
And I actually think that that has had some positive impact. It hasn't solved my problems. I'm not back to normal. But in terms of pain reduction in my knee, I think it worked. So I don't know if you're hearing from other people who are trying, I'm not saying it's becoming more frequent, but it was a legitimate place, Virginia Hospital Center.
yes. Yeah, it's newer. It's not a intervention that's done often,
Right.
uh, but there is definitely some backing behind the efficacy of low dose radiation and joint pain.
Mhm.
There are tons of ads out there for supplements targeting quote unquote joint health. Are any of them effective?
Yeah, I think there are some that are effective in the right environment. But you've got like your osteomyoflex, you've got your collagen, you've got certain vitamins and minerals that they're pushing into media that claim to help with joint pain and the improvement of joint health. And again, the joint itself is a chemical environment, and so there is some backing behind the use of collagen and like an osteobiflex. Osteobiflex is a combination of a couple of different supplements all in one. Jordan being one of them. But I think there is a little bit of efficacy in the use of supplementation because of what happens in a joint. As we talked about earlier, the chemical environment changes as we age or as trauma occurs. Um, so yes, I think it's okay, but nothing is going to surpass the ability to do resistance exercises. Because what happens with resistance exercises is that when tissues are put under stress, they grow. And so we know for a fact that resistance training, what we call closed chain exercises, feet on ground, can help with tissue growth. So if we want tissues to improve, we have to put them under stress, adequate stress, and that means it's usually via exercise.
Are GLP-1s helping at all with reducing inflammation and just, well, the weight loss helps, but just the reduction of inflammation?
Yeah, that's a tricky question. Again, we haven't had enough time to say yes, but some of the warnings about GLP-1s are the demineralization of bone. Um, so on one side, yes, you're losing weight, but it's not always good weight. Sometimes it's muscle mass, sometimes it's bone density. Um, so I wouldn't use a GLP-1 as a means of improving joint health. I think when consulting with your medical provider and in talks of GLP-1s, it's usually along insulin sensitivity, uh, weight management, um, in those worlds. But I wouldn't pull a GLP-1 into an orthopedic setting in that nature.
I have a question. I have knee pain going up and down the stairs, but not standing and walking. And the pain seems to be on the sides of my knee rather than the joint in the middle. Are there ligaments or tendons on either side of the knee that need some PT?
Yeah, you've got a couple. You do have ligaments and tendons on the inside and the outside of the knee. Um, but largely some of those symptoms are still derived from the joint. You can have, and most often, knee pain presents on the inside in the front of the knee, and that is still the joint. It can refer outwards. So I think, yes, the answer is yes. There are some exercises you can do specifically for the ligaments and tendons. Um, but again, most effectively is going to be specific quad strengthening to help stabilize that knee, hip strengthening to help stabilize the rest of the limb,
Right.
so on and so forth.
Okay, thanks.
You're welcome.
In one of your slides, you talked about asking lots of questions of your PT team and getting to know them. And one of the things I was going to suggest is if you're going to talk to a PT team, bring somebody else along to take notes. Because if you're asking and answering a lot of questions, you're likely to walk out of there going, wait a minute, what did he say about this? So just having a disinterested friend alongside to write down everything that everybody says can be very valuable.
I say if you take a pen and paper in and write down your questions, write down your answers, also very effective.
All right. Well, it's 11 o'clock. Does anybody have any final questions, comments?
Thank you very much for having me. This was a ton of fun. As I mentioned earlier, education is one of my favorite things. So any opportunity I get to talk with the community about the benefits of physical therapy and just wellness is one of my favorite things. So thank you for having me. And this was a pleasure.
Yep. And now I think all of us need to get up and go take a walk.
Yeah.
This is great. Thank you so much. Really, really
Yep.
appreciate it.
You're very welcome.
And I know that you're taking time out of your day to do this too. I know our Wednesday morning, 10 o'clock doesn't really work for professionals like yourself. So we're very appreciative of your stepping aside for an hour to help us.
I'm going to put my information in here. So if you have any follow-up questions, comments, concerns, please feel free to email me at any point in time. I'm glad to answer.
And if you want to send us your slides, we can send them to the office to pass along to anybody that's interested.
Very good. Will do.
You said you were at Tyson's Corner. Where at Tyson's Corner are you?
Right off of 7. My clinic's on Boone Boulevard,
Mhm.
right next to Nostos, if you're familiar with the Mediterranean restaurant.
Yeah.
Yeah,
Yeah.
they're right there. We share a wall.
And McDonald's.
Yes, right behind McDonald's.
For those of us who know Tyson's Corner better than we should.
Yeah.
All
Well,
right.
very good. Thank you so much.
Thank
Yep.
you.
Thank you.
I'll leave this up for a few more minutes for anybody that wants to copy anything down.
I love that new word. I mean, if you turn off the recording, Gary, I looked up that word that he used early on, proprioception.
Proprioception.
Yeah, great word.